Welcome to PIPADOR Revise in 5, a series of short, focused revision tutorials for MRCOG. This tutorial is on the topic of combined hormonal contraception and makes reference to the FSRH guideline. Combined hormonal contraception combines a low-dose ethinyl estradiol or EE, usually less than or equal to 35 micrograms, and a synthetic progestogen. Progestogens are synthetic steroids designed to have some of the properties of progesterone and are divided by the time period that they were developed. So first generation includes norethisterone, second generation includes levonorgestrel, third generation includes desogestrel, gestodine, norgestimate, and newer include drospirenone, dienogest, normegestrol acetate. The mechanism of combined hormonal contraception is prevention of ovulation by acting on the HPO axis. This suppresses luteinizing hormone and follicle-stimulating hormone, which inhibits ovulation. There may be a secondary mechanism as well, including changes to cervical mucus, endometrium, and tubal motility from the progestogen. In the UK, there are 3 methods of combined hormonal contraception available: the combined oral contraceptive pill, the combined transdermal patch, and the combined vaginal ring. These methods are highly user-dependent, with perfect use showing a failure rate of less than 1% and typical use showing a failure rate of 9% in the first year of use. All methods of combined hormonal contraception are affected by drug interactions, and the combined oral contraceptive pill is affected by malabsorption. The combined transdermal patch can be less effective in women weighing over 90 kilograms, and all forms of combined hormonal contraception can decrease serum lamotrigine levels. The risks include a small increase in the risk of venous and arterial thromboembolism, breast cancer, and cervical cancer. Traditional progestogens have a lower VTE risk than newer progestogens, and higher ethinyl estradiol doses increase the risk of arterial thrombotic events compared to lower doses. Benefits of combined hormonal contraception include a reduction in risk of endometrial, ovarian, and colorectal cancer for ever use, and more predictable bleeding patterns with a reduction in menstrual bleeding and pain. Symptoms of PCOS, endometriosis, and PMS may be more manageable. Side effects include mood change, headache, and unscheduled bleeding, and no single formulation has been shown to have fewer unwanted nuisance effects. UK MEC4 contraindications to combined hormonal contraception include women who are less than 6 weeks postpartum and breastfeeding, or less than 3 weeks postpartum with VTE risk factors, smokers of more than or equal to 15 a day, uncontrolled hypertension with systolic greater than or equal to 160 and diastolic greater than or equal to 100, current or previous venous thromboembolism, known thrombophilia, current or previous ischemic heart disease or cerebrovascular accident, complicated congenital heart disease, migraine with aura, current breast cancer, lupus with antiphospholipid antibodies, and severe cirrhosis or liver tumours. UK MEC3 criteria include less than 3 weeks postpartum with no VTE risk factors, less than 6 weeks postpartum with VTE risk factors, smoker of less than 15 a day, ex-smoker less than 1 year, body mass index of more than or equal to 35, complicated organ transplant, for example graft failure, hypertension less than 159/99, a family history of venous thromboembolism in a first-degree relative at less than 45 years of age, immobility, multiple cardiovascular disease risk factors, migraine without aura, and known breast cancer gene mutations such as BRCA. Combined hormonal contraceptive works on a 21-day dosing with 7-day hormone-free interval. So for the combined oral contraceptive pill, it's a 28-day cycle with 21 consecutive daily pills followed by the hormone-free interval. For the combined transdermal patch, 1 patch is applied to the skin every 7 days for 3 weeks, followed by the hormone-free interval. For the combined vaginal ring, 1 ring is inserted into the vagina for 21 days, then removed for the hormone-free interval. No additional precautions are required if combined hormonal contraception is started up to day 5 of the menstrual cycle or up to day 5 following a pregnancy loss or termination of pregnancy. For all other scenarios, additional precautions should be used for 7 days. Stopping combined hormonal contraception is not associated with a delay in return to fertility, and there's no arbitrary maximum period of use, and women can choose this until age of 50. It may also be useful for menopausal symptoms and bone mineral density in perimenopausal women who also require contraception. Repeated stopping and starting of combined hormonal contraception should be discouraged because of an increased thrombotic risk. Here is a sample EMQ question from our online MRCOG Part 2 revision question bank. If you would like to test your knowledge further, you can subscribe to this on our website pipador.co.uk.